This is the CT scan of a patient with right-sided sinusitis that basically involves the posterior ethmoid and the sphenoid to some extent. What we can see is a very well-defined soft tissue density inside the posterior ethmoids that is having convex margins, so it's definitely not fluid. It is localized, as well as some evidence of acute sinusitis, some fluid inside the right side sphenoid sinus that could be resolving as well, and with some occlusion of the spheno-ethmoidal recess. You can see that some soft tissue in the sphenoid on the right side as well. So, essentially isolated sinusitis, one could say, of the right side posterior ethmoid and the sphenoid, which as of now appears to be limited. So, what we do is we begin by reducing the concha bullosa in this patient. It requires just a standard incision in the center of the concha and removing the lateral part of the concha that faces the middle meatus. And then that follows a limited sort of an enterostomy just for landmark identification, though it's not really diseased as such in this patient, but for landmark orientation and a general exposure of the sinuses, we recommend that a limited enterostomy be also created at the same time before progressing to an anterior and followed by a posterior ethmoidectomy. Now, as we go from the anterior ethmoids towards the basal lamella using a microdebrider blade, we have always insisted on following the medial or the transitional enterostomy ridge, where the posterior border of the enterostomy ridge joins the superior border to get an exact trajectory, safe trajectory inside the basal lamella to avoid the skull base. And as we go inside the posterior ethmoids, what we see is presence of some kind of soft tissue which we are to discern and identify as to what is the very nature of it, because in a plain non-contrast CT we could only assess limited. Now, as we get the entire face of the basal lamella off, what we see indeed is quite a revelation, and that seems to be a fungal ball that is lying inside the posterior ethmoid. Now, this could be an isolated fungal ball for which the posterior ethmoid is, we could say, an uncommon location. You can see this fungal ball being taken out of the posterior ethmoidal system. As we have located the fungal ball, we can see that practically there is no polyp, no polyposis of fungal mucin, which generally means that it is which generally would have meant that it is allergic fungal sinusitis, but in the absence of any mucin, it is difficult to call it that. It could be either the start of an allergic fungal sinusitis, or it could be an isolated fungal ball that is present in the posterior ethmoid, and if not removed, would definitely progress to go towards the orbit, the skull base, or the sphenoid sinus. Now, once the fungal ball has been simply easily cleared, it is not adhered or anything, it's not invasive, it just needs to be plugged, flushed, irrigated, and you can see the enterostomy and the choana on the right side with the open posterior ethmoid. Now, what is left is the opening of the sphenoid sinus on this side, because we also saw some kind of soft tissue density inside the sphenoid, which was debatable as to whether it is secretions, fluid from an acute infection, or indeed it could be also a fungal disease as it was in the posterior ethmoids. Now, after some clearing of the remnants of the uncinate and the basal lamella, we go towards the face of sphenoid, which appears in this case as a very thick bone. Normally, we palpate this thick bone and we try to identify the ostium, or take a blunt elevator or an olive tip suction, or the face of a shaver blade, which does not point laterally to create an enlargement of the natural loss of the sphenoid sinus. And sometimes it does happen that the sphenoid sinus natural loss is occluded or blocked, in which case we have to resort to a gentle pressure on using a bone punch to increase the opening of the anterior face of sphenoid. But here, now that we see, we are just over the choana, but the bone is very thick and it is practically non-yielding. We are neither able to insert a standard suction inside the sphenoid, nor are we able to insert a bone punch to be able to take down bone from the face of the ostium, and we are also not able to take any elevator, which is normally the case that we do. You can see that this is the nasopharynx. We go towards the choanal arch, and as we go approximately 10 to 12 millimeters up, we should be able to locate the sphenoid os, the sphenoid sinus anterior phase, which sometimes in some patients of certain ethnicities could become very thick and rigid, and in case of an obstruction may not allow any entry of any standard instruments as such. So this is the posterior ethmoid skull base. As you can see, the fovea and the posterior ethmoids. Now the sphenoid is not yet open. Now we resort to using a drill, which is a very uncommon situation for us as well. But in case it is not being opened, so we resort to using a standard nasal drill and drilling on the approximate location of the sphenoid os, which is, like I said, around 1.2 centimeters above the choanal arch, strictly on towards the midline, close to the septum. Again, taking care not to make a straight shot hole, but to use gentle motion of the drill to be able to locate the entry into the sphenoid sinus. And like you can see now that the entry has been made, but it is still small. So the entry is being now enlarged. We can already see that the sinus is opened, but we are just slightly enlarging the entry. Now we understand that the drilling can obviously ensure a thick fibrotic reaction in the post-operative period. So we make sure to widen this sphenoid os or anterior face of sphenoid liberally, so that it does not get stenosed following an excessive fibrotic reaction that normally happens post drilling of the bone inside the sinuses. We are using a Raymond burr here. We are not using any cutting burr, and post a generous opening, we can resort to using our Hajduk-Koffler punch to increase the opening both inferiorly as well as slightly laterally, to be able to secure the fact that this sphenoid sinus in the post-operative area remains not only open for inspection and examination in the office, but also for liberal nasal irrigation, high volume irrigation in the post-operative period, which we would definitely be advising for this patient, whether as standalone or infused with steroids such as Budecort. Now, as you can see that the surgery is nearly complete for us. The sphenoid sinus does not seem to have any fungus inside it. Maybe what was shown on the CT scan was just secretion, has been conclusively open. The antrum is open. So are the ethmoidal complex, the anterior and posterior ethmoids. The frontal sinus is not involved in this patient, so we would not be really going there. And you can see how thick the bone of the anterior face of sphenoid is, and why it was not letting us get an entry inside it. We are going slightly again superolaterally to increase the opening and trying to merge this with the ethmoid to be able to see inside better and more conclusively.